Dayne will be leading our next talk regarding managing joint and muscle pain. So Dayne, as he said, is a physiotherapist. He holds a Bachelor of Science in Physiotherapy from the University of Witwatersrand. He completed his postgrad studies in orthopedics at the International Federation of Manual and Musculoskeletal Physical Therapists. In 2018, Dayne has also completed several specialized courses, including the Mackenzie Lumbar course, chronic pain management, dry needling, and both upper and lower quarter rehabilitation. Since 2020, Dayne has faced significant health challenges, including battling 2 autoimmune conditions, one of which is axial spondyloarthritis. Despite these obstacles, he continues to lead an active lifestyle, enjoying hiking, going to the gym, playing soccer, and a game of paddle. Over to you, Dayne.
Thank you so much, Tanya. I'm just going to organize to share my screen and get the presentation up. I just want to go, click here. Sorry, I just want to go to the front of the beginning of the presentation. Okay. And then I just want to put it on. Okay, so my apologies, it's going to be a lot of theory for this one, but I also wanted, because I knew that I was in the beginning, I wanted to do a bit of more education. So not just purely talk about managing joint and muscle pain for axial spondyloarthritis, but also to talk a little bit about the disease for people who are not educated in what the condition is and how it affects you. It's going to give you a bit of information on like the background of the condition, how it's diagnosed, etc., etc. And then we will get into managing joint and muscle pain later on. So what is axial spondyloarthritis? It's a seronegative spondyloarthritis of the spine and pelvis. The term axial spondyloarthritis has only been used since 2009. Before that, it was called ankylosing spondylitis. So basically, it's just been a kind of a re-understanding, not a re-understanding, but a deeper understanding of the condition. And it's diagnosed through MRIs. So that is something that's important to know. And actually, I realized before I started, I wanted to ask from the group, out of the days of the week, how many days of the week do you experience joint and muscle pain? You can just put it in the chat. You can put 6 or 5 or 7 or 10 days of the 7 weeks. So yeah, let's put it in the chat so that we can see how much of a need it is to talk about. I just want to go to the chat. Okay, so we got a lot of 7s here. Yeah, so we've got a lot of 7s. So basically, it's affecting us most days of the week. So that's why this talk is particularly important for us. And it's something that we want to monitor and kind of keep track of. So yeah, let's go back to the background. So it's a condition that affects the spine and the pelvis. And yeah, so let's go. I just want to move my... So the little window that I can see with you guys, if you put your video on, is just covering some of my slides. Okay, there we go. And this. Yeah. Okay, there we go. So it's described as non-radiographic and radiographic axial spondyloarthritis. So then you've got non-radiographic doesn't show on an X-ray, and the other one does show on an X-ray. So radiographic is basically X-rays. Axial spondyloarthritis predominantly affects the spine with inflammatory causing changes and stiffness, loss of motion in the back. It often causes changes in the sacroiliac joints, epiphyseal joints, costovertebral joints, which is sacroiliac is your SIJ is at the base of your spine where it attaches onto the pelvis. Epiphyseal is your little joints on your spine. Costovertebral is here on your chest. Intervertebral discs, and it causes characteristic inflammatory back pain resulting in structural and functional impairments and a reduction in quality of life. Sorry, it's not clicking now. There we go. So what is axial spondyloarthritis? As you can see, there's a picture of a healthy spine, then there's a picture of an inflamed spine, and there's a picture of what ankylosing spondylitis happens with. It's the bamboo spine where the spine fuses. That's what we're trying to avoid by moving. That's why one of our mottos for our condition and our foundation is motion is lotion. So affected joints progressively become stiff and sensitive due to bone formation at the level of the joint. So basically, if you've got, let's say this is one spine and this is one spine, and then there's a disc in between. If there's a lot of like the edge of the joint is getting pinched or getting pressed upon or getting, that's where there's inflammation, and then the spine can fuse together because there's a lack of movement, which is the movement would be breaking it apart basically. So anyway, so that's that. You can read there. I'm not going to read everything that's on the slides. It's been recorded, so you can go back to look at all the details, but I'm just going to go through what is in general important. So it also involves synovial and cartilaginous joints, as well as sites of tendon and ligamentous attachment. So when I was first diagnosed, I have a neurological autoimmune condition. I would go for runs and then I would get muscle tears and I would get lots of tendon pain. And only when I saw my rheumatologist and then she put me on medication for axial spondyloarthritis, did the muscle tears go away. And now I can run freely and play soccer, and now I'm not getting muscle tears. So it affects a lot of parts of the body. I even had bladder issues, which is not mentioned in my talk. So there's a multiple ways that it can present, and the medication can help those various ways. Okay, so then there's pain. So pain is a big part of AS. So pain in AS can be caused by sacroiliitis, enthesitis, which is inflammation of the tendons, spondylitis, which is inflammation of the joints in the back. Initially, the sacroiliac joints situated at the lumbar part of the back, which connect to the spine and the pelvis, are damaged. Subsequently, the inflammation moves to the enthesis, where the ligaments and tendons integrate into the bone. Eventually, the spine is affected by this inflammation. The vertebral column normally exists of 24 vertebrae, but they join together by ligaments, separated by intervertebral discs. So then there can be calcium deposits on the ligaments. So little pieces of calcium. I don't know if you guys know what calcium is in the body, but it's in your bones, and it's not meant to be in your ligaments. So then the bone it shifts from the bones into the ligaments, and if you've ever had a calcified shoulder ligament, that is what is happening, because there's calcium deposits, which is like a hard crystalline kind of structure that is then found in the tendons. Then you get syndesmophytes, are one of the main features of spinal structural damage in ankylosing spondylitis, is an osseous excretions or bony outgrowths. So osseous is bone, and that's what I was showing you just now in the bamboo spine. Then epidemiology, etiology, it affects 0.1 to 1.4% of the population. So in a room of 100 people, if you go to church or if you go to a conference, and say it's 200 people and you have axial spondyloarthritis, there's a chance that someone else in the room is sitting there with axial spondyloarthritis. So it's very interesting, and I think it helps us to feel less alone when we understand that it does happen to a lot of people. It's mainly happening to people aged 20 to 40. But as Jack has told us, there's a youth group where people are getting diagnosed as young as 16, 15. And a lot of people only get diagnosed after 40, even though they've had it from their 20s or 30s. So I got diagnosed because I had COVID that triggered the autoimmune response when I was 31 or 30, I can't remember. So everyone's different. And basically, you can see the countries in blue are the countries where there's most representation for AS. But South Africa is now also, we're identifying it more, and it's not just a disease that is affecting the Caucasian racial group. It's affecting now more and more racial groups, which is quite interesting. So yeah, I think more research will come out and why it's affecting certain groups and what is the causal factors. Okay, so then there's a strong genetic background in how it's found in people. So that's why Miranda was able to identify it in Jack, because she had a suspicion that it could appear in one of her kids or more than one of her kids. So she did the screening, questionnaire with Jack, and then they found out that he also had it. So this is also something to be aware of if you have children, that you can start looking out for the signs that, when they're teenagers, so that you can, if they're having persistent back pain, going to the physio a lot, this is something that you can help your kids get an early diagnosis and not go through the same cycle that you went through, where you had 10 years before your diagnosis was confirmed, or you had lots of other things that you were diagnosed with. So yeah, it's just it's an awareness, the same way depression and mental health is handed down through genetics. Axial spondyloarthritis is also handed down genetically. And then there's also the HLA-B27 gene, which is an antigen, and it occurs in 90 to 95% of patients with ankylosing spondylitis, compared to 6 to 9% incidence in the normal population. So it's very prevalent. So I'm actually one of the rare AS patients. I don't have the HLA-B27 gene that's positive, or present, sorry. So it's quite interesting, because most of you guys will have this. And I was actually treating a patient yesterday as a physio whose husband has the HLA-B27 gene, and his mom has it too. So yeah, it's very common and very prevalent. Then the characteristics. Inflammatory back pain should be considered if 2 or more of the following features are present. So the one is insidious onset of back pain in the SI joints with the sacroiliac joints, gluteal regions, which progresses to the entire spine. Age of onset less than 45 years, duration more than 3 months, and morning stiffness lasting greater than 30 minutes. So let's see, by just a show of hands or a sad emoji, who has morning stiffness when they wake up? Who has a lot of stiffness when they wake up in the morning that really annoys them and doesn't allow them to get out? No one really is jumping out of bed in this group. That's my guess. So just put reactions on the chat, or you can put a message. Just looking at the messages. Oh, there's lots of crying happening here. Okay, there's sad faces. So yes, so we all in this together. I think that's what we are realizing more and more, is that we are not alone. And I think that's a powerful way that we're going to access healing, is that a lot of the times I've battled with my mental health as well, and now I'm battling with autoimmune conditions. I felt very alone. So now I feel less alone. And I think that's a big part of us healing, is realizing that we aren't alone. So I'm actually going to see if I can put the chat in the corner here, and then just reduce it so that I can still see what you guys are saying while I'm talking. But I know that if you have any questions, please pop them in the chat, and then Tanya will get to them at the end of the call and ask me questions, or someone from the team will do that. Let me just try and reduce this. Okay, no, it's not working. Never mind. I'm just going to exit the chat. Okay, let's keep going. Okay, then the other thing is waking up in the second half of the night. So basically, think about, has everyone ever made a pot of oats on the stove? So when the heat is on, the oats, you can stir them very nicely. So let's use heat as a metaphor for movement and as a metaphor for heat. That's why you'll see when you heat up your joints, a lot of you will move better. Or if you have an electric blanket on all through the night, you won't wake up, like it says, you're at the second half of the night due to pain, because your joints are heated up. If you make that pot of oats, and I eat it now, but say I've got 2 kids and they are still sleeping in, because they're teenagers and they want to eat so maybe I eat my pot of oats at 7:30 and they want to eat theirs at 9 or 9:30. When they get to the pot of oats, it's going to be hard. It's going to be stodgy. So how do we get it moving again? We turn the heat up again. We add a little bit of hot water and we stir. So I would say the hot water is like medication. The stirring is exercise, and the heating up is heat packs. So can you see how the pain that we are experiencing, and that's what we're going to come to later, there's things that we can do to reduce it, and there's things that we can do to increase it. If we sit for long periods in our day in one position, that's what we're going to come to later, our pain in our joints is going to be worse. Okay. Okay, we've gone through all of this already. The stiffness may be noticed after a period of rest and improves with movement. Pain tends to be worse at night or in the early morning, and it's better in the day after moving. So once again, it's linked to movement. Whereas mechanical back pain or mechanical joint pain is if I have twisted this elbow because I was playing paddle. Every time I play paddle, I'm going to have pain. But when I'm lying down in bed, I won't have pain. That's the difference between mechanical back pain and inflammatory back pain. Inflammatory back pain is your arthritis, your autoimmune arthritis conditions, which is what AS is. Okay. Then you've got other things like involvement of peripheral joints, eyes, skin, and the cardiac and intestinal symptoms. The eye disease occurs in 25% of the patients as either iridocyclitis or conjunctivitis. So who has got eye problems? Just pop it in the chat. You can maybe use the eye emoji. Look for that. So I'm just going to check the chat now. Okay. Then there's also joint problems in the peripheral joints. So it's not just a spinal joint problem condition, it's also in the peripheral joints. Then there's also can be breathing difficulties because there's joints that are in your chest. So if your joints in your chest are tight and say you've got asthma already, you're not going to be able to expand your chest as much. Then there's also people who get low-grade fever, fatigue, or weight loss. So I've had massive fever since, not fever, massive fatigue since I got diagnosed. And it has been one of the biggest challenges of axial spondyloarthritis because as a physio, I used to work 8, 9, 10 hours a day. Now I only work 6 hours a day because of the fatigue. So yes, yeah, I know that fatigue is it's one of the common complaints on the WhatsApp groups. Pain and fatigue are kind of two of the biggest, and then mental health is kind of the third. So let's keep going. And can someone on the chat also just tell me how much time I have left because I'm not looking at the time. Ankylosing spondylitis. So then there's the associations. You can go back to that. So these are some of the complications. You can get osteoporosis, uveitis is the eye infections. You can have reduced flexibility, pulmonary function restrictions, increased cardiac problems. You can have fatigue, gastrointestinal disorders. Then there's the medical management. This is what Dr. Ziki is going to talk about later. I'm not going to go into this too much. Then physiotherapy management. So physiotherapy has got multiple spheres of how it helps you. It's not just massaging you. It's not just giving you exercise. As you can see, those are part of what we do. So let's go through the first one. The first one is education. Education is what we do to help you to understand. That's what today is. Today is I'm educating you on your condition. Then there's therapeutic exercises, which we're going to come to later. Then there's behavior modification, which can be the posture that you're sitting at your desk, or the type of couch that you're sitting on every day, or the pillow that you use, or the way you stand, or the way you cross your legs, or the way you sit with your legs. So changing our behavior can change our pain. Then there's joint mobilization, which is actually pressing on each individual joint. The physio will do that. There's breathing exercises, which can reduce a lot of pain. I've been doing a lot of breathing exercises with my patients lately, and it's helping their pain massively. Then there's soft tissue mobilization, which is massage. Hydrotherapy, getting in warm water and moving around in the warm water is very good. And then the other modalities like ultrasound and dry needling and tape. So yeah, there's many things that we can do. And then, okay, so physiotherapy is an essential part of the treatment of AS. It aims to alleviate pain, increase spinal mobility and functional capacity, reduce morning stiffness and correct postural deformities, increase mobility, improve the psychosocial status of the patient. According to the Cochrane review completed by Dagfinrud, sorry, and the colleagues, a supervised or individual-based, home-based exercise program is better than no intervention. So can you see that some exercise is better than doing nothing? So for some other conditions, like say you've got a sprained ankle or something else, you want to not move, you want to rest. But with AS, it's the opposite. It's not like when you've twisted your knee or you've hurt your disc or something like that, then you rest. Okay, so it's a different condition. We need to approach it differently. So then there's soft tissue mobilization. So there's massage. I would just be very careful. I've had a lot of patients. Something that I do want to mention is that I wouldn't recommend Thai massage. It can be very extreme, and a lot of my patients who go to Thai massage can come back injured more than they go when they go there. So just to something that's gentle. If you do prefer a sports massage, book that with a masseuse or a physio. As you can see, there's also someone using a roller here that is very useful for certain people, but sometimes it's too painful. So I'm of the type of physio that is like, do what works for you. So don't push yourself to the level what another person is doing. Do what works for you, but you got to find what works for you. You can't just do nothing. So you have to explore different things. Okay. Then there's heat packs, these ones that wrap around the neck or wrap around the back, or you can get ones that go all the way along your back, are amazing. They really have changed my life and they've changed a lot of other people's lives. Then there's therapeutic exercise. So these are the three main types of exercise. You've got strength exercise, you've got cardiovascular exercise or aerobic exercise, and then you've got mobility and stretch exercise. I would even add a third one being proprioceptive exercise, a fourth one being proprioceptive exercise, which is linked to strength, but I believe it's slightly different to regular strength exercises that a lot of people are doing at the gym. I just want to quickly check the chat if there's anything related to what I've been speaking about so far. Okay, so we get 15 minutes left. Thank you. Okay, great. So that's all sorted. And then we've got sciatic nerve glides. So one of the things that I've realized, neural mobilizations are very underutilized by physios and very understood by patients, because basically a lot of physios are treating muscles and joints and not treating the nerves enough. And I've seen in just discussions with a lot of my friends and the fellow volunteers and other people that have got AS, is that their nerves are often getting pinched. So to understand how to glide the nerve through the tissue is also an important tool, and it's something that we can definitely look into. And I can post like very basic gentle nerve gliders on the WhatsApp groups and on the Facebook group. It's just difficult to do everything now because it's more of a talk that's meant to just be educational, but I'll do more practical things. I can post them on the group so that it can be done at a later stage. Then proprioceptive exercises are very important. If you have more balance, your joints are more stable. If your joints are more stable, there'll be less pain. So you start with very basic things like standing, like you can see this man on the red mat is standing with 2 feet down. So that's easier than on the guy that is on 1 foot and the guy on 1 foot on the blue mat. So you start with something easy and then you build it up. And when your joints are more stable, you'll have less pain. And proprioceptive exercises are very easy to do. You can literally do them while you're waiting for the kettle to boil. That's what I tell my patients to do. I tell them to stand on one leg while they're waiting for the kettle to boil. When they're brushing their teeth, stand on one leg. So balance exercises, proprioceptive exercises are much easier to integrate into everyday life than a 30 or 40 minute or 50 minute or an hour gym session or a run or a walk for half an hour. So I really like proprioceptive exercises. Then let's talk about the pain and activity traffic light. This is how you are going to decide what activities you can do at a certain time of your life, a certain time of your condition, a certain time of what's happening with you. So let's start with the green light, the safe zone. The green light is basically you do an activity, let's say it's walking, to the park, walking around the park, and it's a 1 to 2K walk. You do the walk like we did that for our social for the Joburg group. We did the walk. No one complained during the walk. No one complained after the walk. It was a safe zone. There was maybe minimal pain, 1 or 2 out of 10. So this is out of 10. This robot is looking at pain out of 10. 4 to 5 is acceptable, but it's not optimal. So that is, there's some pain. So I always look at it as like safe zone is pain. There's a little bit of pain and it's fine. 4 to 5 is its pain, but when you stop, does the pain continue? So say it is running, and when you're running on a flat surface, you have 0 to 3 out of 10 pain. When you stop, the pain goes down. But when you're running on a hill and you have 4 to 5 out of 10 pain, and when you stop, then the pain is still throbbing in that joint. That's a sign that the joint and the body is irritated and it's not enjoying that activity. It's not loosening, it's actually irritating. So I believe in a sliding scale. With AS, if we lie in bed too much, so let's say it's this side, let's say it's this side, lying in bed too much, we're going to have more pain. Doing too much, we're going to have more pain. So it's basically like, I don't want to get political, but I believe that too much of the political world is very radical left or radical right. And there's not enough centrists who are just kind of calm thinking people that are not radical in either extreme. I believe the same for pain. We have some people who are radically just lying in bed all day, doing nothing. And then we have other people who are overdoing it. And that was me, because I was so used to not overdoing it. I was so used to being very active that when I got diagnosed, I still went and ran, and I pushed myself, and then I had a muscle tear. Then I pushed myself, and then I had a joint pain problem, and then I twisted my ankle. So I have now done much better by being in the middle and sometimes pushing myself. Oh, then that day I pushed myself a bit too much. Okay, next time I'm not going to run as far. I'll just do 5Ks, not 7Ks. So, and then excessive, you can see, is there's just, you flare up, you're in pain, you don't want to be there. Okay. You can go back to look at the different types of exercises on the talk when you check on the on the YouTube page. So this is different options for you to check out. And then deep breathing. I want us to do some deep breathing. I know we're going to do it later, but it's just something that I am realizing more and more is very important. If you are anxious in any way, and if you have a tight chest or a tight back, so literally just taking deep breaths into your diaphragm is something that I want you to do, because it's going to be helpful for you. I'm not going to direct you, because Tanya will do it later, but just if you know anything about deep breathing, take a few breaths. You'll see your anxiety will calm down. You'll see that some pain can even be reduced by that. So let's do a bit of deep breathing now while I'm talking about deep breathing. And then there's a thing called a longer exhale. I don't know, Tanya, did you add the longer exhale to your deep breathing part? Okay, it's fine. I can come back to it. Tanya, just let me know if you did add the longer exhale, because we had spoke about it, adding it to your talk. If you didn't, then we'll come back and do this together. Then considerations for the prevention of pain. I'm just trying to reduce there's like a little bubble with, okay, let's just do this. Reduce. Okay, there we go. Okay, so fatigue is a common complaint in rheumatological conditions. It can be managed by taking regular micro breaks, avoiding sitting in the same position, maintaining physical activity, and having good sleep. Sleep is vital. I'd say the 4 pillars of health in general, not for AXSPA, is sleep, diet, exercise, and emotional health. How you handle stress. Those are like my 4 pillars that I tell a lot of my patients, and social circles and engagements. So let's say 5 pillars. AS patients can suffer from flare-ups of increased disease activity, which can last days to weeks. During the flare-ups, the patients may benefit from gentle stretching exercise, taking breaks, and medication. Joint protection management applies to ergonomic principles. So ergonomics we're going to come to. Patient compliance can be achieved by determining barriers facing the individual, including the patient's exercise preference. So don't just do an exercise because you've always done it or because your friend does it. Find what works for your pain. I was chatting to one of the volunteers. I'm not going to talk it. She does aerial yoga and she loves it. But when she's in a flare, we've told her to just do as I was a physio, I've told her to do basic gym and a little bit of walking and Pilates. So she's not going to do aerial yoga when she's on a flare. So you adjust your exercise accordingly. Okay. And then that's all good. So this is your activities of daily living. They're all important. As you can see, everything is mentioned here. And you need to tell your physio, when I am gardening, there is pain. When I am having sex, there's pain. You need to be really honest. If you're not comfortable with your physio, you need to find a physio that you're comfortable to talk about all aspects of your life where there could be pain. Because if there's pain in something, you're not going to want to do it. If you loved gardening in the past and now you have pain every time you garden, then you're not going to want to do it going forward, and you're not going to enjoy your life as much as you did. Or you need to make adjustments, like have a chair in the garden, a little chair, not go onto your haunches. So there's many ways of dealing with pain in activities. Then ergonomics, you can see there's a sitting person here, there's a half sitting person and a standing person. So this is with a desk that goes up and down. So that's very helpful. They're all good postures. They're just different types of postures. And the main thing about ergonomics is that it's not just having good posture, but varying the postures that we put our body through. So if we're sleeping, we want to roll often and change positions. If we're sitting, we want to kind of move our legs and move our shoulders, do a little rotation, look up, twist a bit. So basically it's changing postures. And that's basically it. Let's see, are there any questions? And then we can answer them and leave it there.